Today's talk is really going to be twofold. The first is going to be about a concept development. It's currently in development. We're still kind of sketching it out. And the last is going to be a pitch to many of you in the room. So today we're going to talk about the consolidative therapy in lymph node positive and low volume metastatic bladder cancer. These are disclosures, none relevant today. Novel therapies have dramatically shifted the field for advanced bladder cancer, and we have been looking at these curves for the last couple of days, and they are impressive. Just EV and Pembro really doing a much better job compared to standard of care cisplatin gemcitabine, with all the caveats that was spoken about earlier. And when we look at this, what we see is that the patients who have lymph node only disease, those patients are having response rates of nearly 80% with a lot of complete responses. And when we look at the progression-free and overall survival rate for those patients, those curves are quite impressive. And so now we are using this more often in clinic, and we are coming to a new, or at least a more frequent clinical scenario. So this is one of my patients, 60-year-old gentleman, new diagnosis of muscle-invasive bladder cancer. Staging scans show that he has enlarged pelvic and para-aortic lymph nodes with no other evidence of disease. You can see here that an FDG PET scan was obtained. You can see that lymph node lighting up there. So he was started on EV and pembrolizumab, and after 3 cycles, he has a complete response. And we even did one of these ctDNA tests, and it goes from something to nothing. After another 3 cycles, he's still in a complete response. And so I sit right behind the urologist in my clinic, and the urologists say to me, well, should we do something more for this person? Can we be even more aggressive? Should we think about taking the bladder out or doing something to the bladder, giving definitive therapy? So the discussion about consolidative therapy for cancer has been going on for a while now, and it's really been looked at for other disease processes, and not so much with bladder cancer, though we'll get to a little data. So one of the disease processes that we're very familiar with in this room is prostate cancer, and the slide is a little bit cut off for me, but hopefully you guys can see. So Stampede took patients and randomized them to radiation to the primary. And for patients with low volume disease, radiation to the primary actually improved failure-free survival and overall survival. And again, patients with low volume hormone-sensitive prostate cancer. And just released today is the article for Piece 1 looking at the role of radiation to the primary. And in Piece 1, for patients who were treated with ADT and abiraterone, when you did radiation to the primary, that actually improved radiographic progression-free and time to castration resistance, so actually did not significantly improve overall survival. Again, patients with low volume disease. But although the prostate is very close to the bladder, it doesn't really have a lot of biological relevance to it, but maybe one that's a little bit more like bladder cancer is non-small cell lung cancer. So here's one study that looked at the role of consolidative therapy for non-small cell lung cancer. This was a study by Gomez. They took patients with metastatic disease, oligometastatic disease, had 3 months of systemic therapy, and then randomized them to either receive continued systemic therapy or systemic therapy plus consolidative therapy to the primary and sites of metastases. This study actually closed early. With only 49 patients treated, there was a significant benefit in progression-free and overall survival. This really suggests that maybe there is a role for consolidative therapy in some disease processes. So is there any data about consolidating patients when they already have known sites of disease outside of the bladder? Well, one of the studies that was done was Matt Galsky looked at the National Cancer Database. Matt Galsky and his team looked at the National Cancer Database for patients who had muscle-invasive disease, who had lymph node positive disease. And what you can see here is that overall survival was significantly improved for the patients who received systemic therapy and cystectomy compared to those who received just cystectomy alone or just chemo alone, suggesting even patients who had N2, N3 disease, they might benefit from having the bladder taken out if they have a significant response to treatment. We looked at something similar. This was a study that was really led by one of our fellows, We looked at the VA database and through Vinci, and we looked at 5-year overall survival for patients who had lymph node positive prostate or lymph node positive bladder cancer. And cystectomy actually improved or was associated with an improvement in overall survival and cancer specific survival at 5 years. And so it at least provokes the question, is there a role for consolidative therapy for patients with clinically lymph node or low volume N1A advanced bladder cancer? And here is the study that is still in concept that we are developing. So you take patients with limited advanced bladder cancer, start them on frontline therapy, and if there's no significant signs of progression, maybe you randomize that patient population to systemic therapy alone or systemic therapy and consolidative therapy to the bladder. Now, I really like this concept. I think that it has a lot of weight, but there are a lot of questions like, which are the exact patients that we enroll? Where is their clinical equipoise? N2, N3, M1A? Would you put patients with lung mets on? What's the required response that you would have to see? Would you take patients with complete response, partial response? Do the patients with complete response, do you actually leave those alone if they have absolutely no evidence of disease? We just don't know. And then the type of consolidative therapy. I wrote here surgery and chemoradiation. I think those are certainly the most studied, but whether or not there may be a role for other intravesical therapies. So here's the pitch part of this talk. So we have developed a survey that was going to be unleashed next week, and it's going to go out to many of you in this room and to many other people, looking at current practices for patients with N2, N3 disease and low volume advanced bladder cancer, and getting clinicians' input about potential clinical trials in this space. So this study will take about 10 minutes. Think about it. Do it not on Thanksgiving, but maybe over your Thanksgiving break. Thanks so much for your time. This is my email address in case you want to chat.